Thank you for all of those who are joining the webinar. We'll just give people about a minute or so to join, and then we'll start. Okay, I think we can start, and the others will keep joining us. And I just want to say good morning, good afternoon, and good evening to all of you who have taken the time to join. If you have not done so, would you kindly introduce yourself in the chat function, just your name, perhaps where you work and which country you come from. My name is Chilunga Puta, and I'm a senior immunization data advisor for the Momentum Routine Immunization Transformation and Equity Project, in short, MRITE. I'm pleased to introduce today's webinar on using data triangulation and to identify zero dose. And my apologies, I forgot to put on my yes, I'm happy to introduce today's webinar on using data triangulation to identify zero dose and under-immunized children. But before I do that, I'll just go a little bit over the Zoom environment for this webinar. We do have interpretation today. And if you are French, for example, you go to the interpretation icon there below at the bottom of the screen. It's got interpretation. You click on that and you select the language that you want to use. And please note that we are using the chat feature to introduce ourselves and to share your thoughts during the presentation, but the questions that you want answered must go in the Q&A button. The Q&A button in the Zoom function. So use the Q&A button, please, for the questions. And then if you need help, again, do not use the chat to ask questions. The questions you ask must go into the Q&A button. And remember that are only visible to you, our presenters and technical support. I will collect your questions for our speakers and save them for the discussion period following the presentation. The webinar is being recorded, and following today's event, you will receive an email with a link to the recording. If there are questions that do not get answered during the Q&A session today, we will forward them to the presenters and share the responses by email to all the participants. Can I have the next slide? Now I would like to introduce our great speakers today. I think we can start with Carolina Danovaro and Dr. Anna Morica. They'll be our main presenters. Carolina is a medical epidemiologist. She's an immunization analyst at Immunization Analysis and Insights team at WHO. Dr. Anna Morica Trejos is a medical epidemiologist and pediatrician. And then there's Dr. Ranjendra Bohara, who's a team leader at IVD WHO. He's a polio guy and is very experienced in immunization. And then we have Angela, who's one of our guest speakers. Angela is an epidemiologist at the Global Immunization Division at CDC in the US. She actually has led quite a bit of this work on using triangulation to find zero-dose children. And I think that's all the speakers for today. I'll just go through the agenda. And today what we'll do is I'll just briefly, very briefly describe MRIT, the Momentum Routine Immunization Transformation and Equity Project. Then I'll give a brief overview of the zero-dose child toolkit and tell you a little bit about the learning exchanges, this series that we're doing. And then there will be the introduction to using data triangulation to identify ZDC by Carolina and Anna. And then there will be a panel discussion, which will be combined with Q&A after that. Hopefully then we come to the end of the webinar. You'll be expected to do an evaluation and you'll be given a link for that in the chat, or else you can just swipe whatever they call it at the end of the presentation. So to kick off then, next slide. At the Momentum Routine Immunization Transformation and Equity envisions a world in which all people eligible for immunization from infancy throughout the life course are able to access high quality vaccination services, particularly those that are vulnerable, underserved, and marginalized, those who are likely to miss vaccinations. Why? Because we do want them to be protected against vaccine preventable diseases. The MRIT project was awarded in July 27. Can you lift this up because I've got something covering your... Okay, thanks. 2020, and it's for 5 years. And we have country programs at 18. Next slide. Okay, so what does ZDC toolkit? And please, may I bring to your attention that at the end, we'd want you to suggest what we could call this kit. And why did WHO actually generate this draft toolkit that we're working on now? I think it's because there is a problem with current administrative data systems. We failed to accurately quantify and localize ZDC children. And this is recognized particularly in low income and low and middle income countries. So it is important then that we should have guidance for the countries to help them locate these tools. And as a result of this, this toolkit was actually designed and is being developed. Okay. What does it want to zero in? Well, it's an integrated approach. It also connects with existing tools. So it wants to be able to identify non or unvaccinated communities and zero-dose and under-immunized children by using a decision-making criteria and combine tools to decide if you need to do it, when you need to do it, where you need to do it, how to go to the field to conduct rapid convenience assessments or targeted probabilistic surveys and take actions to reach, vaccinate, and follow up on non and under-immunized communities. The toolkit is linked and complementary to already available manuals and guides. Next slide. And how are we refining this tool? We've got 3 approaches. One, we have a design collaborative of 5 to 10 countries who will have an in-depth look at the toolkit. Then we have these learning exchanges where we are hoping to learn from our audience and to learn what can improve, what can we do, what are the needs, what are the gaps, what should we include, and so on. And then we will have a field test in Nigeria, and we use the case to see how the revised toolkit performs in that natural environment. So those are the 3 approaches that we've taken. Next. Okay, and so today's topic, which I'm introducing, is using data triangulation to identify zero-dose children. And I think at this point, I am going to allow our two speakers to take over and make their presentation.
Thank you, Chilunga. I think it's my turn. Hi, good morning, afternoon, evening. I'm Carolina Danovaro. I was introduced already, and I work with the Global Immunization Monitoring Team in WHO. We have been working, and some of you have already seen a draft guide on, we don't have a good name, so please, please, please think about a good name. But what's included in the draft is guidance on how to do data triangulation, and then to define if, where, when, and how to conduct targeted field assessments. They can be surveys or rapid convenience or LQAS or some other tool to identify and reach non- and under-vaccinated communities and children. And as a reminder, the Immunization Agenda 2030 calls for a world where everybody has access to the benefits of vaccines. So really, equity is at the heart. And one of the indicators towards that equity is to reduce the number of children who have never received a vaccine, the zero-dose children who are now monitored as children not receiving any dose of diphtheria, tetanus, pertussis vaccine containing. And then to reduce that number by a quarter by 2025 compared to pre-pandemic, and then by half at the end of the period of the implementation of the immunization agenda, which is 2030. The next one is the next slide will guide you what we will be talking about. So what's data triangulation? We talk about it, but really, so we have a common understanding of what we are saying when we say, let's triangulate data. And then how this type of triangulated analysis can be used to identify areas where we may need to dig deeper. And then from the results of the triangulation, really understanding if we have enough information to take action, or if, where, when, and how we can and may have to go to dig further through targeted field assessments. So the next slide just shows how a definition of data triangulation, and it's this idea that we're all partially seeing the elephant on the right here, and we are trying to describe it with the parts that we can touch and see, but how we synthesize existing data from two or more sources to address relevant questions. So question is a key word here, and more than one data source is another key part of this data triangulation. And then for doing something about it, so for planning and decision making. So in the absence of really perfect data, we understand that we can do better by combining different pieces of weaker evidence to have a strong basis for improved decision making. And as important of combining the different pieces, it's to put the thinking, to really, it's not a formula. And I think what we're trying to propose here is a guide to help you with the critical thinking that is required to be refining the questions, interpreting the data, and then using that information that we are learning for action, with the important component of repeat. So always assess, am I doing well? Checking and then doing better if you need to. The next slide shows the triangulation in a 4-step process, and this is already in the guide that's available in TechNet on the triangulation process, with asking the question. What's your question? What are you trying to understand? Then identifying the data sources that you already have and summarizing that data and in the context of your local area where you are. And finally, develop a plan of action. This is not news. It's a way just of organizing your own mind in how we're going to go about the step triangulation process. Some colleagues are joining here, and we're in a triangulation workshop, for example, a couple of weeks ago in in African region. The next slide shows that this guide, what it will help you, it's to think critically with the decision tree support. So first step, think about what you want to do. We want to identify communities that are or under-vaccinated that appear to have zero-dose people and under-vaccinated people. So first question is understanding if they really, with the data that you have suggests that yes, that they are in clusters or in groups or in specific areas or if they are more broadly disseminated. And then to go to the next step of whether it's possible to characterize the communities that you are identifying as probably having many children who need to get more vaccines. So then you can decide if you have all the data you need, you can take action, but you also can decide that you may need to define and need to collect some more data to guide you in that action, in that action that is needed to better understand what action you will be taking. The next slide shows that in the toolkit, it's all about supporting with the decisions, asking the key questions, identifying key data sources, not only your routine admin data, but also from routine, from campaigns, from population estimates, from surveys, data coming from surveillance, from outbreaks. What are we learning from those outbreaks? What are they happening? Have we done vaccine effectiveness analysis? Are we doing risk assessments? And there are many acronyms in the slide, but they are described at the bottom, where we need to better understand the behavioral and social drivers, the availability and readiness of services, any missed opportunities, etc. And then how we gather, prepare, examine, analyze the data to then see if we have everything to answer the question. The next slide is just, again, asking key questions on the who, where, how many, and why. And it's important to understand that the evidence suggests that the answers can be really different, even in the same country, about the whys of why people are not being vaccinated at all. It can be very different from why the people are not completing the schedule. The next slide shows that in the guide, we list the different data sources with the strengths and limitations. Again, we have to triangulate data because we don't have one source of truth. So we really are trying to put the elephant together from the different pieces. And the toolkit lists a lot of existing guidance that already have through WHO, through UNICEF, through JSI, through different partners, and how you can optimize the use of the different tools. The next one. Importantly, the toolkit here goes to describe the step of assessing data quality. So really understanding in this example, you can see data from, it's coverage data from district level, and is supposed to represent different municipalities. And you see the time frame that we are looking at is different. So you can see that, for example, the number of people vaccinated may be similar, but then coverage is fluctuating. Might it be the denominators that are a problem? What's happening in another place that maybe you are seeing a decline in the denominator, which is suggesting that you have high increasing coverage, but in reality, your number of doses are very similar. So really, the first step before using the data is to assess the consistency and the logic. And I will pass the next slide to Ana Morise, who is the author of the toolkit. And she has done several toolkits for neglected tropical diseases, for example, which is, again, populations that are vulnerable and neglected, and immunization for Latin American countries as working with PAHO. Ana?
Thank you, Carolina. Okay, once you ask the key questions and collected and identify the data sources and assess the quality of the data, you need to summarize the data and also consider the local context. So knowing your countries, not only the country, the subnational level, the local level is very important. This is a teamwork. And again, this is about asking questions and finding the best answers. Here, we need to answer who and where are the zero dose and under-immunized children. Where are they? What are the characteristics of those areas? As you can see here, this is an example. You have some areas colored in red. So what are the characteristics of these red areas compared to the green areas? Do under-vaccinated persons belong to any specific population? Because we know that zero-dose children have been reported that they live in some rural areas or slums, or some of them are migrants or nomadic populations, or very close population, ethnic minorities. So we need to try to find, through the triangulation process, the answers to these questions. And of course, you need to make a decision and take actions. So how many are them? What proportion of zero-dose children you anticipate that you will be targeting in those communities that you already identified? Or do we need to use alternate denominators or survey data? So these are some examples that are described in detail in the toolkit. Next, please. And to answer those questions, you need to consider two main aspects. Are these children hard to reach or hard to vaccinate? Because the situation could be different, and maybe they are both. They are hard to reach and hard to vaccinate. So you need to assess what is the importance, the weight of each one of these type of barriers. And here are, again, some questions. Are they demand-related barriers? As an example, related to lack of confidence with vaccine benefits, or any situation that is affecting the demand? Or maybe there are some social and political or gender-related barriers that you need to consider. But maybe the barriers are related to the health service, to the immunization services. Maybe this population are not vaccinated because the distance of the facility is not near to the community, or because they have stockouts, or because they don't have enough resources. So it is important to consider these two aspects, these two types of barriers. The next one, please. So as Carolina mentioned, maybe triangulation won't be enough to find the answers to those questions. In that case, you need to implement other field assessments. So you need to go to the field, and you can have rapid field assessment or probabilistic surveys. Here are some of the methods that you can use, and we know that many countries are using, as an example, LQA or rapid convenience monitoring, and we have a colleague from Bangladesh that is going to present that in the second part of this webinar. And the other thing is that it's not only covers, it's important also to find answers to the whys. Are those reasons related to the facility or to behavioral and social drivers? So these are two considerations that we need to take into account. The next one, please. And finally, the last step of triangulated analysis is to interpret results and for taking actions. So basically, this is what I mentioned before, is to implement vaccination activities based on that analysis and the interpretation to reach the no vaccinated and zero-dose children. As Carolina also mentioned, maybe you will need to implement different actions considering the different contexts, even within one country. And the two questions that we need to ask again before implementing the actions is if these actions would change those barriers in a sustainable way, and what interventions are needed to reduce this population, how feasible they are, what resources do you need, how can you ensure that the impact of those interventions will be sustainable, so it's not a one-time intervention. The last slide, please. So this is a summary of this approach. As you can see here, we started with the triangulated analysis, and if we need, based on this first step, maybe we need to implement rapid fields assessment to find answers to this question. To data quality, maybe data quality is not good enough for taking actions. Maybe we need a probabilistic survey to estimate how many zero-dose children are in the country and what are the reasons. Maybe you know or maybe you can estimate how many, but you don't know the why. So maybe you need to implement field assessments to have answers to know the reasons why they are not vaccinated. And also if a rapid assessment will be enough, or you need a probabilistic survey, and also the timing. So when and how the immunization team needs this information. And if you implement a targeted survey, if that decision is to implement a targeted survey, it's not only a targeted survey to estimate the coverage. As I mentioned before, and Carolina as well, you need to assess the whys, the reasons why they're vaccinated. Maybe they are related with community access, or to behavioral drivers, or to facility readiness, as we mentioned before. And again, this targeted survey is not only to answer the questions, is the most important thing is that we need this information for taking actions. The next one, please. So now I'm going to introduce Dr. Rajendra. He's a colleague from Bangladesh, and he's going to share with us their own experience in using this kind of combined tools.
Thank you so much. Again, greeting from Bangladesh. Here it is 6 o'clock in the evening. I don't know, many other part of country maybe it's morning. Anyway, greeting from the Bangladesh. I'm really pleased to share what we are doing here in Bangladesh to identify and reach non and under vaccinated children and communities. Next slide, please. This is just a glimpse of photography here, the celebration of World Immunization Week. So Bangladesh is generally considered as high-performing country. The GRF showed this more than 90% coverage over a decade. Additionally, more than 83% of children under 12 months of age receive full immunization. However, despite of the strong performance of the immunization program, progress remains uneven, posing a challenge in ensuring comprehensive coverage for all children across diverse socioeconomic groups, geographical region, and especially in the urban slums. To address the challenges posed by the COVID-19 pandemic and to ensure the immunization of every child, Bangladesh organized catch-up vaccination campaign drives nationwide as a part of celebration of World Immunization Week in all consecutive 3 years, 21, 22, and 23. And we have reached almost 2 million children with all necessary antigens during this catch-up vaccination campaign. Next slide, please. Now, we had, here a question, since Bangladesh coverage is quite high, where are these zero-dose children and who are these zero-dose children, and how to identify these zero-dose children? Are there every part of the country, or are there in certain areas, So we had this question in our mind, and then we thought, okay, let's use some tools to identify these zero-dose children. So we used like data triangulation method. I really want to thank Angela. I saw her here. We did a lot of work back in 2019 on data triangulation with CDC US. So we also use rapid convenience assessment, house-to-house monitoring, and data triangulation to really identify these zero-dose children. And also we assume that maybe these zero-dose children are in urban slums, maybe Chor area, maybe Haur area, or a geographically hard-to-reach area. We really wanted to see where were these zero children. And also we wanted to see what is the relation of these zero-dose children with primary health care services like delivery. Is there any relation? Is there any relation with the ANC checkup? Is there any relation with the TD vaccination? We also wanted to see that relation. The next slide, please. So initially, we in Bangladesh, there are, I would say, 3 kinds of coverage evaluation survey done. One is coverage evaluation survey that is generally supported by UNICEF and WHO. There are also BDHS survey, usually USAID does that, and also mixed survey generally supported by UNICEF. And the other one we did was rapid convenience assessment. And when we looked, different the numbers with the different surveys, and we could see, almost same picture with the zero dose, almost 0.3, 1.1%, almost similar. But under immunized children, we see very high, up to 16%. And similarly, all these 3 surveys, both coverage evaluation survey, BDHS, and also RCS. So almost same figures, like usually the under-immunized children with MR2 is like up to 16%. So we use these different surveys just to know, whatever the number or percentage of children, zero dose and under one, and also under-immunized children. Next slide, please. And also use, GIS. We went down up to the Upazila level to see where were these zero dose children. And you can see in this map, this is a map of Bangladesh, and you can see, especially the Dhaka, that is the capital, Dhaka city, very densely populated, and some area of Chittagong, Sylhet area. We just didn't go up to the district, but we went below the district, sub-district level to try to see really where are these zero dose children. I have put a link. You can go to this link and see, in detail how we really try to, identify zero dose children up to that grassroots level. Next slide, please. We also try to triangulate, we have a very good, measles and rubella surveillance system in the place, and also AFE surveillance system in the place. We also try to see what is the relation, between those measles outbreak, let's say, and MR coverage. Since this is a case-based surveillance, we look for each individual child. What is the vaccination doses? Is 0 dose or more than 3 dose? And also we do a house-to-house around the outbreak site to see whether there are any 0 dose children in that area or under-immunized children, because we also do outbreak response immunization around that outbreak site. So we try to triangulate those, outbreak data with the 0 dose children, and also similarly also the AFE cases, because we also take a vaccination history of each individual AFE case and try to see are there, problem with the vaccination in those areas where there is the cases are being reported. Next, please. So then we thought, okay, let's do a rapid convenience assessment. So we did 3 rounds of rapid convenience assessment. We started in May 2022. Then initially it was supported solely by the surveillance network of WHO. Then in third phase, we also brought together the other partners like UNICEF, Collect, and also government Collect together. We did together, the third phase of rapid convenience assessment. And in that, we try to see a minimum of 60 children per district, like 10 child per catchment area ward, and at least 1 child per house, where the adult child should be at least below 2 years. So I would not say this was scientifically, approved, but we thought, let's see, those areas, what is really happening, So next slide. So we also, the second thing what we really did is develop this real-time data visualization dashboard. We did a house-to-house monitoring, our surveillance network. They go to house-to-house and do a monitoring, and you can easily see here. I don't know, I cannot open this. You could easily see. I mean, you can you just open that link? I don't know whether you can. Maybe if you can. Otherwise, we have this dashboard. Anyway, we'll be sharing this presentation with you. You can go and you can see, each district or Upazila, or you want to see by division, you can see by urban, slum, and all the information available about the 0 dose and under-immunized children. Next slide, please. So this rapid convenience assessment, like I told you earlier, we visited almost 24,000 children, and then urban it was like 31%, rural it was 69%, and if you look boy and girl ratio, almost 52 to 47%, and we found 0 dose almost 1.7%, penta 1.7 is not very high. And if you look under vaccinated children, missed 1 or more scheduled dose, it was like 5.5%. Received vaccine at least BCG penta was 98.3%. Fully immunized 12 to 23 months was almost 94%. And if we take MR2 as a fully immunized, then it was like 89% coverage from this rapid convenience assessment. And we did this rapid convening throughout the country. It's not in particular one area. You can see in the map here, this was done throughout the country. Next, please. Like I told you earlier, we were wondering, are there zero dose in this particular area like Chor, border area, or ethnic community, or Haur area? And also we try to look those areas where there are no health workers, a vacant position of health worker, like urban slum, So what we found was really, we didn't find really a high, zero dose children, like 1%, you can see from here. We didn't see really a district like, oh, this area is the one with highest zero dose. Urban, we found around 2.5% urban slum, but otherwise it was almost same. I was really too surprised because I also went some of these Chor areas. I thought I would find a high number of zero dose in this Chor area because these are area in middle of river, sometimes they submerge with the water when the river is big. Then again, it comes out, So I was expecting I would find more children there, but it was not like that. Around 2.5 zero dose children, which is 0.06 million. Yeah. Next slide, please. Then, like I told you earlier, we also try to see relation of these zero dose children with the some of the primary health services like delivery. Around 40% of children we saw in those mothers whose deliveries were at home. Again, I'm not telling it might be scientifically correct, but whatever number of mothers we interviewed during this 3 phase, you can see here. It was quite, significant, like 40% zero dose, who deliver at home. Next slide. Similarly, we also try to see what is the relation with ANC. The Bangladesh provide 4 ANC checkup is quite low. We also found like 23% zero dose children, and those mothers who didn't receive any ANC services. So that was also really very interesting thing for us. ANC antenatal care services. Thank you so much. Next one, please. And also there is a very, the zero dose are under-immunized increase with the mother's education. Higher the education, I would say less zero dose are under-immunized, So especially in the pre-primary or the mother's education is pre-primary and non, a little bit higher, here you see higher secondary 1.6 multiple they got from the private, but usually lower the education of mother, higher the percentage of zero dose and under-immunized children. Next, please. So then we started having these GIS-based microplanning and mapping. We have a support from WHO headquarters. I don't know, Robbie joined here today. I don't know. Otherwise, you would also give his insight. We have just started in 3 places just to see and use this GIS-based microplanning to reach those unvaccinated children. Next slide, please. Yeah, this is just exercise, the field level that they are doing, it's really very interesting. There is a link here, so you can go to those links and see how really it helps, really tracking up to the lowest level to see, certain, health facility, whether they are near to the community, whether they are far, So it's really very interesting exercise. So those who are interested, you can go to that link and see. We have just started, and we'll be very happy to share once we complete this whole exercise. We have 3 colleagues, international consultant here in the country to support this, and we would definitely like to share that when this is completed. Next, please. So we try to see this accessibility to healthcare, travel time analysis, and also the relation to zero dose. We found also here some kind of a relation here. Although Bangladesh is a very plain area, it's not a mountainous. In only some part of area is mountains. Otherwise, it's generally plain area. But we could see some relation there between the accessibility to healthcare and travel time and also zero dose. So we found that kind of relation. But again, like I told you earlier, we have just started this GIS-based microplanning, and we'll be very happy to share with you once this is completed. It will take another 1 to 2 months for us to complete. We have started as a pilot project in 2 district and 1 city corporation. As soon as that completes, then we'll have much better idea in coming days. Next, please. So in conclusion, I mean, with this high coverage in Bangladesh, we're really, wondering to really trace these zero dose children, and so that we could have a targeted intervention in those areas to achieve high coverage, or really bring down those zero dose children. So we use this various method. Not only one method may not work. So data triangulation, RCA, house to house monitoring. So various methods just to find those children, because it varies from place to place. So we would after we complete all this use of these tools and also GIS microplanning, we will continue to refine these tools and technologies in future, so that we can really have a good I would say a tool in place to really identify these zero under-immunized children, and so that appropriate action, or target action can be taken, other than just blindly going throughout the country. That will really help us in reaching those children with the minimal resources. Next slide, please. I think this is the last slide. Again, thank you so much, and I will be very happy to share with you some GIS microplanning in future when we complete this. Again, I'd like to thank everyone, and also our WHO headquarters and colleagues in the country, really supporting this effort. Thank you so much.
Thank you very much, Rajendra. That was very, very interesting. I think we can move on to the poll question now. I'm sure Carolina is very keen to have this done. Who's projecting the poll question?
So remember that we have a toolkit with no name yet. So we really want to hear, after hearing what the toolkit will do, what do you think we should name it? Understanding the parts that it has. So please take the poll.
Kindly go in and give some names. We don't have anything so far, and we really do want to hear from you, and want to move on to the discussion. So I'm giving people at least a couple more minutes.
Please vote. I put in the chat the elements in the draft guide. So keep them coming. We are getting some answers. So please. So we have many people in the webinar. So please, if you get a chance, just type some of the keywords that we want. Yeah. Thank you. We see some suggestions in the chat also, but put them in the poll if you can. Thank you. You can also send us proposals of titles after you see the slides and reflect a little more. So Chilunga, do you think we can move on, or do you want to give another?
I think we can move on since you've given them the option to have homework. Okay. Okay. Thank you very, very much, Carolina and Anna and what's the other guy's name? Our Bangladesh friend who's got millions of Rajendra, who's got millions of questions in the QA chat. And maybe I can quickly start with those so that I can give him a chance to answer. The first one is the RCA in Bangladesh. How were HH and neighborhoods actually selected? Do you feel that the HH visitors were convenient and therefore likely to be a bit biased, high, or were the teams directed to areas unlikely or wildlife, something likely to have low coverage, and so maybe representing a worst case or lower than average coverage? Can you answer that, Rajendra?
Okay, thank you so much. I mean, yeah, I mean, we included all. There are 61 districts in Bangladesh. We included from each district. We took two upajillas selected randomly, which makes total of like 128 upajillas. And also from each upajilla, this is sub-district. Upajilla is sub-district, and municipality. 3 unions were selected again randomly, and from each ward, I mean, 12 children were selected, you know, and then I mean, from city corporation, we selected 2 zones from Dhaka, South and Dhaka. These are the big city corporation, and 1 zone from other. And then we did this RCA randomly in selected ward and zone. Although we try to, you know, when we selected, of course, we try to look those areas, like I told you earlier, there are thousands of chor areas, you know, Haur areas, urban slums. But we selected randomly these places, you know, so that there is no bias, I would say. And for a union, we 36 houses were visited in each, like areas with slums, Haur, Bill, you know, we selected those areas, you know, especially so that we're assuming those area would have this 0 dose and under-immunized children, you know. So though we selected those area to know, you know, just to make ourselves, you know, confident that these are the areas where are the 0 dose children, you know. But that was not really the case. Yes.
Okay, thank you. I'll go on to another one. Again, it's for you, Rajendra. It's from Zili. What's the source of the satellite images in the Bangladesh project? Are satellite images available to all countries through WHO that could be used for microplanning?
Yes, we have. I mean, currently we are doing in 2 districts and 1 city corporation, and we got those. We supported, of course, you know, government to get those satellite images, and also we also got technical, like I told you earlier, technical support from our WHO headquarters, that the GIS unit. We have 2 international consultants currently in the country that are supporting us. This GIS microplan. Yes, those satellite maps, yes, we supported at the country level, and also we got support from the our international consultant. Like I told you earlier, this RCA is not a survey, so it's convenient bias, I would say, monitoring in prioritized area. You know, that is what I told you when in the beginning, because we visited those areas that we thought would have, you know, 0 children.
Okay, great. I think this one I'll give to Carolina. It sounds more like a Carolina question. What have you seen to be the most effective ways to communicate data to non-health and decision makers who can provide support for reaching zero-dose children and families?
Thank you. I don't think I have the best answer because I think it varies a lot by the type of user of your information, the type of audience. And I think even understanding that we are a bit not so good at getting at understanding the needs of our audiences. So from what I have read in the literature, really, it has to be a very short message, a very short actionable message. For example, the two concrete things that a community can do. For example, we see that mothers are saying that they cannot get to the health facility because they close too early or they are working. So the concrete thing is give that message, and then how can we expand hours of operation or dates of operation? So I think it really depends on in trying to keep the message simple, pointed, and really try to understand our audiences. And I would pass it to anybody else who wants in the panel wants to say something about this, because I think I'm not the best even in communicating some data to non-technical people. So anybody who wants to take it.
I was going to ask Angela actually to see if she's had any other experiences that she can share with the group. Angela?
Sure, thank you. No, I definitely agree with Carolina. I think it's very important for us to consider who our audience is going to be when we're presenting any sort of data triangulation type information. We've, in our experience in trying to build the data triangulation capacity, we've also focused a lot on sort of most optimal data visualization practices. And so there's some great resources out there that I'll try and either share in the chat here or we can share with everyone that's registered after the presentations. But the European office has a great communication toolkit for immunization related data that we can share also in the chat. So I think just like Carolina said, really making sure that we're using the most appropriate data visualizations that really drive home the point that we're trying to make very succinct descriptions and interpretations of the data that we're seeing, and then also be very, very clear about the ask that we have for our end user or our audience. What is the action that we would like them to take? Because that's really the take-home message.
Thank you. The rest of the questions are mostly about Bangladesh, but I think I want Anna to also contribute to this one. With more than 90% of coverage rate, I think it was hard to find and reach ZD children. Please, can you provide detail on method you used? I mean, I think you should go to Rajendra first, and
yes.
then Anna can.
So thank you. I'll ask my colleague Hassan also to comment. Hassan, are you there? Is our data manager there? Hassan? Hassan, are you there?
I think he's left.
Hassan? Hassan, are you there?
I think he has left, Rajendra.
No, I think he said, yes, I am.
Oh, okay. I didn't hear him.
Hassan, are you there?
Yes, I'm here.
Can you respond to the question? I mean, Hassan was the one who directly got involved in this. Hassan?
Yes, actually,
Yeah, can you yes, explain the methodology of RCM.
Actually, the methodology of RCM, we started building calculate the sample size based on the we took the sample size of for calculate the sample size based on our coverage evaluation survey. That the coverage of last antigen we counted and calculate the sample size. After that, getting the total sample size for whole country, we segregate the sample as per the domain. What Dr. Rajendra said, that each district we collect, we took 2 upazila, and each upazila we segregate 3 union. After that, each union we collected 36 household information, and 36 household information we get we took purposely, and all other information like upazila, union, and district, that is selected randomly. And another methodology, another thing we taken care of, that priority area. Actually, we collect the cumulative the priority area, like how job, low coverage area, and where HR shortage. So 5 priority area we considered, and inform them that in the union you have to ensure those priority area if you have there. So you need to prioritize that area, and you need to select 36 households from that priority area. So and beside that, we done a data triangulation thing to select the district. Actually, so district data triangulation thing, we how we observe that surveillance data we considered, as well as immunization data for selecting the district level districts. So in that way, we come up those 24,000 child. That's it.
Great. I think we'll move on to the next question, just because we've got so little time left. Again, it's about Bangladesh. Thank you so much, Rajendra, for that presentation. In a setting like Bangladesh, where coverage levels are high, it seems like the percentage of 0 dose that's missing DTP1 seems small, although numbers may be large. Are there thoughts on other definitions or indicators to define 0 dose beyond DTP? I will refer this one to Anna.
Okay, well, that's a very interesting question, and we always said that 0 dose children is just the way to improve coverage. So I think if the country is the percentage of 0 dose children is very, very small, it's important to be more ambitious, to have another indicators, so that we can improve the coverage. Not only the coverage of the first basic schedule of immunization, but also to have fully immunized children. So I agree with that comment.
Thank you. Angela, would you have a few words to throw into that in the last minute?
No, I don't think so. I think they covered most of the points, I would say.
Carolina?
Just to thank the participants and thank Bangladesh and the MRI team for the invitation and for being with us. And please, please, please send your names for the toolkit. Thanks.
Thank you. Okay. I think we have to call it come to a close because we just have 1 minute left. But before we do that, can we go to the last slide? We need to have an evaluation. Oh, you're already there. Good for you. We need to have an evaluation. You can either scan this QR code, or is there going to be a link in the chat? Is there a link in the chat?
Yes.
Okay. Please use whatever you find easiest. We need to have an evaluation. So kindly do that. And yes, it's only 2 minutes or so. So although we are on time. So with that, I I just want to thank the excellent panelists and presenters. Thank you so much for all of you who came. We are really encouraged by your attendance. And please don't forget Carolina's name for the toolkit. We really want a nice toolkit for this. So with in the next few days, you should be receiving an email with a link to today's recording, so you can go over it again, and you can, catch those things maybe which you did not have time to do to catch, or it was fast. So you've got another chance to go through it. So with those few words, I just want to thank everybody once again and bring this webinar to a close. Thank you so much. This has been really nice, actually. Very good audience, very good questions, and a special thanks to Bangladesh. Thank you for sharing your, your experiences. We all live on those experiences. So thank you so, so much. Thank you. Bye-bye.
Bye-bye. Thanks.